Alrighty. Oh, sorry. Thanks for everybody for showing up again. Tonight we're going to be talking about ankle fractures. Want to thank Dr. Sirkin, who is one of our traumatologists who provided us the majority of these slides. And I want to thank Joe Galloway, who put this talk together. He was supposed to give it, but unfortunately he got stuck into the OR. So Joe Ippolito, PGY4, and myself will give the talk. But as always, before we go on, we'll do some review questions from last lecture, which was on knee ligamentous injuries. So let me pull up the poll. This one we didn't really talk about, but if you guys want to give it a shot. So ACL injuries are more common in males, females, or dogs. I don't really know about number 4, but.
Did you look up the rate in dogs?
I didn't. Sorry, Jeff. I didn't.
I've seen dogs that have had ACL repairs.
I know that my sister has a Great Dane, and they're pretty common in Great Danes. But
those are exceptional athletes.
In the overall dog population, I'm not sure.
Probably because of the Q angle.
Yeah. Alrighty. So let's share the results. And you guys did a great job. So yeah, it's about 4.5 times more common in females than males. Jeff or Joe, do you want to just go over a couple of reasons why that's the case?
Sure. So it's more common in females. Some of the reasons are the actual structural differences between men and women. You think wider hips, it changes the angle at the knee. That can be measured as either the Q angle or thinking of an inherent valgus deformity to the knee. Additionally, there's some studies that show that there is also a correlation with hormonal changes that are resultant in overall changes in ligamentous or tendon laxity. So that can change the strength of the tendon at that level, especially at the ACL.
Cool. And as you guys can see, there's a bunch of more different reasons that you can go and review on your own. Question number 2. So if you guys logged into our Instagram, we had a similar question posted the other day on this. So what is injured when the dial test is positive at 30 degrees, but it's negative at 90 degrees? Jeff or Joe, can you guys just say what the dial test is and what makes it positive?
Are we saying what makes it positive now, or are we waiting for the answer?
Don't we have to take the quiz question? Are you trying to cheat?
No, what's the dial test? How do you do it?
The dial test, you put a patient, it's easier to do it supine, but you actually can do it prone or supine, is where you examine the external rotation of the legs at both 90 degrees and 30 degrees. A significant value is more than 10 degrees of asymmetry between the external rotation on the injured side compared to the contralateral side. And by putting different structures of stress in different locations or different flexion, it tests different ligaments throughout the knee.
Alrighty, so let's see how everybody did. So again, majority of you guys got it right. Nice job. So yeah, at 30 degrees, it's the posterior lateral complex. And then if it's at 30 and 90, it's the posterior lateral complex and the posterior cruciate ligament. All right, question number 3. So if there's a posterior sag sign, this physical exam finding may trick the examiner to believe that there's also an injury in what? The PCL, ACL, medial, or lateral meniscus. tricked you guys. Jeff, you want to go over what this is? And
Yeah, so the image at the bottom shows you the posterior drawer test.
The screen, but we don't see your screen. We haven't been seeing it.
really?
Is there other slides?
Yeah, there's slides.
Yeah, we don't see it.
Weird. I can see it.
Yeah, they're coming
I
up.
don't know.
I can see the screens.
Oh, it's not working for me. That's so weird. Okay, never mind. It's just me.
Okay, so basically we're comparing the posterior sag sign is something that you note when there's a PCL injury. Basically, if you put the knee in the position as shown in that image below, although that's showing a posterior drawer, you note that the tibia will be able to fall posterior in relation to the femur because the PCL isn't there to prevent that posterior translation. The way that this can be sometimes a trick is that with the knee resting in a posterior sublux position, by doing an anterior drawer, you will feel a significant translation as the knee is reduced back to its normal anatomic location. So you may think you have an ACL injury rather than a PCL. But the trick is that as you're doing the test, you need to both feel for the translation in anterior and posterior direction, but as well as a firm versus a soft endpoint as to whether there's actually an ACL injury that is, or an ACL present that is providing a firm stop to that anterior translation versus the soft tissue surrounding the knee that would give you a soft stop to your anterior translation.
Thanks. Alrighty. And our bonus question. If you guys had superpowers, what would it be?
Is this professionally or otherwise?
Whatever you want. Yeah, number 2 would
Have
be
to find out who the creepers in the group were.
number 2 would be great for orthopedics. You don't have to use fluoro, you just see everything.
That was my question.
Alrighty. Kind of all over the board. We already know that Joe already has super strength, so he doesn't need to choose that one.
Really nice Photoshop work, Jeremy. Really good stuff.
I'm awesome at it.
You make that on MS Paint?
Time restraints.
Strong work. Extra call for me.
What's your answer, Joe?
X-ray vision.
All right. And Jeff?
Make the trauma bay really convenient.
I'd probably go with mind reading.
I don't want to know what people are thinking. It's too much information.
Yeah.
I agree.
Let's do it.
Alrighty, let's go on to ankle fractures. So we're going to go through some anatomy, classification system, some radiographs, talk about the treatments. We'll also touch on parts of the ankle and post-op care, and then there's some case presentations at the end of this. I apologize. It's a little bit all over the place. As I said before, Joe was supposed to give this lecture, but he got tied up in the OR, so we're doing this on the fly. So the ankle joint itself, I only have part of an ankle joint. I don't know where the rest is. But it's made up of the tibia, fibula, also have an articulation between the tibia and the talus, and then the fibula and the talus. And each of these articulations are supported by a bunch of different ligaments. When you look at the distal tibia, it's going to be a little bit wider at the anterior portion than the posterior portion. And then if you compare it from medial to lateral, it's going to be wider on the lateral portion at the infrastructure. And then if you look at the talus is also shaped in a unique way, and it's a wedge shaped and it's wider anteriorly. So the majority of the time, if you put the patient up in dorsiflexion and you bring that anterior aspect of the talus up in the ankle joint, you're going to get some more stability because of the wider shaped talus. So the medial malleolus also has a couple different features. There's an anterior colliculus, and there's also a posterior colliculus. The deltoid ligament is on the medial side of the ankle, and there's two portions of it. There's a superficial portion and a deep portion. And the superficial portion attaches to the anterior colliculus, and the deep deltoid attaches to the posterior colliculus. The purpose of the medial, the deltoid ligament, is that it prevents lateral displacement of the talus.
One little thing, Jeremy, to throw in. I always used to mix this up because of the superficial MCL from last week. We talked about having being the strongest restraint. This is the deep deltoid, which is the strongest restraint. Just something to always flip in your head.
Yeah. And I don't know if he touches it on this later, but you can have an injury, a fracture through the anterior colliculus that you can fix, but you can also have an injury to the deep deltoid. And if you don't fix that, then you can still have some instability in the ankle. So you have to realize that you have to fix both of these because they attach to different parts of the medial malleolus. So going on to lateral malleolus, this provides some lateral support to the ankle. And it sits in a groove on the tibia, which is called the incisura. And if you guys ever pull up CT scans and look at the incisura, you're going to notice that it has a really variable anatomy. Some patients have really curved incisura, and then other ones are nice and flat. So it's interesting to just take a look at that. So what makes up the stability of the ankle? As we said before, that there's bony anatomy that allows for some bony constraints of the ankle. There's also ligaments that attach these bones, and then there's the joint capsule. And the combination of these adds to the stability of the ankle. The ligaments are very important when it comes to ankle fractures and injuries. And there's a syndesmotic ligaments. There's also lateral collateral ligaments and medial collateral ligaments. So the syndesmotic ligaments are ones that we talk about very frequently, and they're made up of four main ones. First is the interosseous membrane, and that's going to run in between the fibula and the tibia. There's an anterior inferior tibial-fibular ligament, or the AITFL, and that's this structure here. Posterior to that is the opposite, the posterior inferior tibiofibular ligament. And then there's the transverse tibiofibular ligament. So all four of these make up the syndesmosis. The posterior structures are stronger. So that posterior inferior tibiofibular ligament is stronger than the anterior one, and therefore the anterior one ruptures more often. Because of the strongness of the posterior PITFL, there's more often fractures of the posterior tubercle or the posterior malleolus. The transverse ligament is also part of the posterior one, and this deepens at the posterior ankle. This, out of all the ligaments, this one's probably the least common one, or the least talked about ligament. And then you have your interosseous ligament that is an extension of the interosseous membrane, and this allows for some transverse stability. So like we mentioned before, there's the deltoid ligament on the medial aspect of the ankle, and there's two parts, the superficial and deep. And the superficial attaches to the anterior colliculus, like we mentioned before. And you can see this on this depiction here. So this is a lateral of the ankle. This is the medial mal. And you can see that this is the anterior part of the deep deltoid, and that's going to be attached to the anterior colliculus. And then the posterior colliculus attaches to the other portion of the deltoid ligament. So the deep deltoid, as we touched on before, attaches to the posterior colliculus, and this also helps prevent lateral displacement. And that, like Joe said, the deep one is more important. It's going to be the stronger of the two ligaments. There's also fibular collateral ligaments, and there's three of these. There's the anterior, calcaneofibular, and posterior. And these are often talked about when you have ankle sprains. I think we touched on this in a previous lecture about how to diagnose whether if the anterior or the calcaneofibular ligaments are disrupted. So I'll just skip those. So when we talk about ankle injuries, there's a vast differential and different types that can occur, and has to do with the patient's age, their bone quality, different types of directions of forces, different magnitudes, high energy or just low energy with just twisting mechanisms. And all this plays a part in what type of ankle fracture you get. And then we can diagnose what type of ankle fracture, and then that will play a part in what type of treatment that you have to do for those ankle fractures. So there's two main classification systems that we use, the Dennis-Weber classification system, and then the Logie-Hansen classification. And so the Dennis-Weber classification is for just the fibula fractures only, and it determines on what level of the fibula fracture is injured. So it goes from A, B to C, and it starts inferior and then works up. So A is going to be infrasyndesmotic, so any fibula fracture that's below the syndesmosis. B is going to be transsyndesmotic, and then C is going to be suprasyndesmotic or above the syndesmosis. The level of this fracture will help determine stability and help determine if we need, how we need to fix these. Yeah. The next classification, like I mentioned, is the Logie-Hansen classification, and there's 4 different types: supination adduction, or SADs, supination external rotation, or SER, pronation abduction, or pronation external rotation, or PERs. And this classification has to do, there's 2 different words for each of them. The first word is the position of the foot. So how's the position of the foot when the injury occurs? So this can either be in supination or pronation. This, let's get back to, yeah, I'll go. The second word is going to be the mechanism of the injury. So either external rotation, abduction, or adduction. So when you use about the first word, you have to think about the position of the foot. So whatever side of the foot is tighter, that's where it's going to injure first. So if you have a foot in supination, if you just kind of do this to yourself, you can feel that the lateral side of your foot is going to tighten. So that's where you're going to have your first injury. If you have a pronation injury, the medial side of your ankle is going to have the tight structures, and that's where it's going to be injured first. Like I mentioned before, the second word is going to be the deforming forces, or what type of mechanism or energy caused that injury. So it could either be adduction, abduction, or external rotation. So we'll go through each individual ones and then put it all together. Yes. So for supination external rotation injuries, these are the most common. They're going to occur about 90% of the time. And the characteristics of this is the medial malleolus is going to be a transverse fracture. And then your fibula fracture is going to be a spiral oblique fracture. And it's going to be a Danny Weber type B. So it's going to be transsyndesmotic. So let's see if there's a picture. We don't have to go through. Each of these has different stages, and each stage is a different type of progression of injury. It's a little bit too complex for, I think, the realm of this talk, but so the spiral fracture is always going to start pretty much at the syndesmosis or at the plafond, and then it's going to spiral outward and upward and cause an oblique fracture. The orientation of that fracture is going to be anterior inferior to superior posterior. You'll hear in a moment that this is going to be in contrast to your pronation external rotation. The pronation external rotations also have a spiral oblique fracture. However, it's in the opposite orientation. So these supination external rotations are anterior inferior to posterior superior. The pronation external rotations are the opposite, and they're anterior superior to inferior posterior. And that's going to differentiate those as well as one other thing. So let's skip these stages. The next one is supination adduction. So this one is unique in that of the four, it's the only one that has a vertical medial malleolus fracture. And the reason why is for these injuries, the foot's in supination, and then the talus is driven medially into the, hold on one second, let me see if I have, thought I had a foot model somewhere. Here, I have a talus here. So in these injuries, the foot's going to be in supination, and then it gets driven up into the medial mal. And so that driving force displaces the medial mal fracture superiorly and causes a vertically oriented fracture. And then because of that supination and adduction force, there's a tension on the distal fibula, and that's going to cause a transverse fracture. So in these supination adduction injuries, you have a vertically oriented medial mal. It's the only one of the four that has this, and then has a transverse fibula fracture. And that's often most of the time, a type A Danny Weber fracture. So it's going to be very, very distal below this syndesmosis. Also, we call these SADs, and they're SAD in the fact that they have some impaction on that distal tibia. So yeah, I guess you can see here that the talus here gets supinated and gets driven up into the medial side of the ankle, and then causes this vertically oriented medial mal. And then there's a tension failure of the distal fibula to cause a transverse fracture. Next one is a pronation abduction. So this one also has a transverse medial mal fracture. But what makes this one unique is that it has either an oblique fracture, that's a Danny Weber type B, or most of the time it's going to have comminution. So if you ever see a fracture with a comminuted fibula at the level of the syndesmosis, with a transverse medial mal, it's most of the time going to be a pronation abduction injury. And then the last one is pronation external rotation, or PER. And this one is also going to have a transverse medial mal fracture. And then it has a high spiral fracture. So this is going to be a type C Dennis-Weber fracture. And like I mentioned before, it's going to be oriented in the opposite orientation of your supination external rotation, or SERs, and that this is going to be anterior superior to posterior inferior. You can see that orientation here on the lateral. So again, it's going to be anterior superior to posterior inferior. So again, just to recap, there's 4 types. The only type that has a vertical medial malfracture is your SAD. The rest of them are going to have transverse medial malfractures. Then if you see a fracture that's comminuted and either at the level of the syndesmosis or above it, that's going to be your pronation abduction. If you have a medial mal that is transverse and a low spiral fracture, that's going to be your SERs. And then if you have a medial malfracture that's transverse and a high oblique spiral fracture, that's going to be your PERs.
Jeremy, I don't know if you touched on it, if you wanted to touch about why a supination adduction type fracture pattern is important to recognize preoperatively, and maybe how this might change your plan.
Yeah, I think you're probably getting at the impaction at the talus, at the distal tibia. And that's important to pick up on because it's going to have some impaction at the surface right here. And so you have to either see that, and often in those you get a CAT scan to further assess that impaction. And intraoperatively, you have to address that. So you have to put some type of osteotome or a freer in this area and then push that back down so you can restore the articular surface of the distal tibia. If you don't recognize that, then you're going to go on to arthritis quicker.
Yeah, the other thing, and again, maybe I missed you saying it, but it's that you think about your fixation method. You sometimes see people fix medial malleolus fractures with screws because of the vertical shear. If you guys remember all the way back to our earlier lecture on buttress plating to resist vertical shear type fracture, this will often get a buttress plate to better resist those forces. Because if you put screws across this, you run the risk of displacement of that medial malleolus superiorly.
Yeah, I think there's case presentations that will touch on this, but as Joe was saying, oftentimes we get screws here, but in the SADs, we'll put a plate here, and then your most important screws right above the fracture to create an apex here, because this vertical oriented fracture is going to want the medial mal to displace this direction. So you create an axilla here so it doesn't want to go in that direction or can't go. And then you put another screw here, and theoretically that's all you need, but then often we will put lag screws in to augment it as well. In these injuries, the fibular fracture is also treated a little bit different. You'll see in the case that we often use lag screws for those oblique fractures, but in this case it's transverse, so you can either put a screw up the intramedullary canal and that's great, but it's not rotationally stable. So a better construct is to put a tension based plate on the lateral side of it, and then some screws proximally and distally. So then you prevent any type of motion in the axial plane, but then also, you prevent your rotational deformities as well.
Very nice, Art.
Thanks. See what else is in this. And then there's vertically loading, and then these are either combination injuries or most likely pilon fractures. Pilon fractures are different from ankle fractures in that ankle fractures are rotational injuries. These pilon fractures are a vertical axial loading, and that causes a fracture to the tibial plafon. So when you see these in the emergency room, you get three views: your AP, your lateral, and your mortise. Again, your mortise is about 10 to 15 degrees of internal rotation. And you want to get a sense of how much overlap of the fibula and tibia there is. So you look for this medial border. And on the AP, you want it less than 5 millimeters. When you get, there's the distance between the medial side of the fibula and your incisure. That should be 5 millimeters. You can also measure the medial aspect of the distal fibula to the lateral aspect of the distal tibia, and that should be about 10 millimeters. But most of the time we're looking at our mortise x-ray, and we're comparing the distance here at the medial clear space to the superior clear space. So this distance here should be about equal to here. If you see an increase in this medial side, then you know that there's some injury to the deltoid and the syndesmosis, and then that needs to be addressed operatively. So this medial clear space is just an augmentary number of 4 millimeters, but it should be really more compared to your superior one, because patients are different sizes and shapes. So this number is quoted, but it should be more just a comparison. We can also look at the talocrural angle, and this is addressed on the mortise. And so you draw a line at the distal tibia at the plafon, and then you draw another line from the tip of the medial mal to the tip of the lateral mal. And this angle should be about 83 degrees. And you can use this angle to address your length of your fibula. And this is important when you're addressing this in the operating room. Your lateral x-ray is also going to give you some important information. It's going to allow you to assess for a posterior malleolus fragment much more easily. And as you can see here, there's a large posterior mal fragment that's here. And then you can just further address the articular surface. There's a step off here. And then also, when I was mentioning the differences between your SERs and your PERs, you're going to look for the obliquity of your fibula fracture. So if you see a fracture that's in this orientation, where it's anterior inferior to posterior superior, that's going to be your SER. If you see it high and in the opposite direction like this, that's going to be your PER, because it's, again, anterior superior to posterior inferior. So it's important to get your three views of your ankle, because each of them will give you different information. So like everything in orthopedics, we have to determine if it's operative or non-operative. And it comes down to the stability of the ankle. So it's not so much of getting a reduction, because it's very easy to reducing an ankle and getting it to become anatomic, but it's more so of maintaining your reduction. Because if it's unstable, you're going to be able to get this reduction, but you're not going to be able to maintain it. So when we're talking about non-operative fractures, it's usually undisplaced fractures. A lot of the time, if it's isolated malleoli, like an isolated distal lateral mal fracture, those are going to be stable. Often we'll treat things non-operatively if the patient's too old or too sick to undergo a surgical procedure. And then sometimes we just temporize it and get closed reduction just to realign it. Operative, like I said, is going to be anything that's unstable. So if there's some incongruity of the joint that's greater than 2 millimeters, if there's bimalleolar injuries, that affects both the medial and lateral side of the ankle. And most of the time with those, you're going to see some mortise displacement. So the talus always wants to go with the fibula. So you're going to see a lateral displacement of the talus. And then if there's any articular impaction, you're going to treat those operatively, because you want to restore your articular margin so you decrease the rate of post-traumatic arthritis. So we'll touch on some fibula fixation. And here's just a picture. The majority of the time, you're going to be treating these with either a combination of a lag screw with a neutralization plate, or if it's comminuted, you're just going to get the fibula out to length and then put a quote-unquote bridge plate. And so you can put these plates on in two positions. You can either go direct lateral, or you can go posterior lateral. And they each have their own benefits. So like I said, you can use a lag screw. The buttress plate is your posterior lateral plating, because in your SERs, there's going to be a superior posterior spike. And so you're going to be putting that plate on the posterior lateral aspect to resist that spike. So you can kind of see it here. So you're going to put it there to resist that spike from translating. If you do use lag screws, you always have to back it up with a neutralization plate to prevent other means of rotation and shortening. The medial mal, like Joe mentioned before, the majority of the time we're going to be using lag screws, and you want these lag screws to be perpendicular to the fragment so that you don't displace your medial mal. You not always, I don't want to say always, but the majority of these times this should be an open reduction, because there's often periosteum that's flipped inside the fracture fragment. And if you don't take that periosteum out, you're never going to get a perfect reduction. So a lot of times you'll see people just do a closed reduction by putting a clamp on it and then throwing screws up it, and there's still a little gap there, and that's because the periosteum's there, and so you need to address that and pull it out. So these should be open reduced the majority of the time. And as you can see here in this photo, a lot of times we'll do 2 screw constructs, but here you can also, if it's more isolated, just do one of the colliculi, like the anterior or posterior, you can get away with putting a pin in. The reason why you want to do more than just 1 screw is for rotation. So if you just put 1 in, even though you compress it, it'll still be able to rotate around that screw. So you need another point of fixation. And so like we touched on in earlier lectures, you can either do this by a lag by technique where you over drill the outside of the bone and put a fully threaded screw, or you can do it by design, as you can see here with these partially threaded screws. Joe, you have anything to comment before it looks like we're going to case presentation?
No, I'm just responding to some good questions in the chat. Where they were just talking about a couple things about plate options, which I think you kind of touched on. One of the questions was when to use a 1/3 tubular plate versus an anti-glide plate. How to kind of consider some of those differences. Some of the things I was talking about, which might not be really a textbook answer, but was considering the bone stock of the patient, the benefits of distal locking options and an anti-glide pre-contoured plate versus the increased cost. And then, the options that a 1/3 tubular plate yield you, especially in a young patient, if you're using a lag screw and using it as a neutralization plate, and just some of those considerations. And then just to not forget, everyone, I think oftentimes people think that there is no locking options in a 1/3 tubular plate. That's not true. You do have 1/3 tubular plate locking options. So it's just things to consider. And I think, at least I don't have a perfect answer, textbook answer for when to use which, other than in a comminuted ankle fracture where I'm not really getting much compression or lag, especially if they're older with bad bone stock. Those pre-contoured plates are sometimes nice with all the distal locking screw options. And then otherwise, I would try to do as much as possible with a tubular plate, lower cost, and I think it's more biologic fixation.
Yeah, I agree 100% on what you just commented last. I think on comminuted fractures, it's nice to have those multiple locking options distally.
You want to pop into some cases?
Yeah. So
cool.
Does anybody want to have a stab at what you see, or if not, Joe can go over what he sees in these radiographs? All right, no bites.
Oh, hold on. Someone unmuted. Oh, patience.
I was gonna say I can try.
Right, do it.
Okay, it looks like a AP lateral and a mortise view of the ankle in a skeletally mature individual showing a trimalleolar fracture.
All right. What
Cool.
What orientation of the fractures do you see? If you can go through.
Yeah, so the medial malleoli looks like a transverse fracture. The fibula looks like it has, I'd say, a transverse fracture also. And then the posterior mal looks like vertical.
All righty. Joe, you want to comment?
So, trying to scrutinize his lateral X-ray here.
No, me too.
If that's a trimal, if that's just the fibula overlapping, but I do see a disruption of the articular surface there.
Yeah.
So, yeah, I think that was fine.
Yeah.
What do you want to do?
So
how do you want to fix it?
I think it's important for posterior mals, you can follow what you know. So this is articular surface, and then you can wrap it around and then bring it up. And then you see there's this ending here, and it doesn't correlate to this part of the tibia, which is here. So there is that little spike there that makes it a little posterior mal. And then I agree with you 100%. This is nice and transverse. And then it's hard to see this fibula fracture on the lateral. So yeah, I can't really comment, but I see it here and here. It's kind of hard to see. I wish that we had better X-rays.
Yeah, who made this presentation?
Yeah.
Call them up. Pull them out of the OR. Just one comment to make. Oftentimes, you get orthopedic surgeons pontificating over fixation of the posterior malleolus. One thing that we generally still abide by is about 25-30%. If it's less than that, usually we don't chase after it. If it's more than that, something that we go after. There is some emerging schools of thought that say that potentially, fixing even these smaller posterior malleolus fractures improves your postoperative ankle stability. A lot of that is yet to be determined and proven, early research still. So, but that's kind of the general number. If you're getting pimped on rounds, what's big enough to warrant fixation, what's small enough to probably leave it alone. I think 25% of the articular surface is generally still the cutoff that at least I would use if I'm on the stand morning report.
Yeah. And Kate, is this ankle dislocated, located? Is there a lot of deformity? What do you think?
It doesn't. It looks like it doesn't look dislocated to me. There's no like increased medial side spacing. And the talus looks like it's in correct alignment with the plafond.
Yeah.
Anything you want to do before fixing it? Any other imaging? So it's kind of hard sometimes, at least for me, to understand and calculate how much the articular surface is involved. So one thing that can help further delineate treatment is a CAT scan after these injuries. And so nice little study published at our institution that said that obtainment of a CT scan changed operative management, operative planning amongst trauma surgeons in more than a third of the cases. So sometimes you pick up some interesting findings, especially if you've got trimalleolar fracture. There may be more energy and more things than maybe you can appreciate on the x-ray. And so CT can be valuable for those purposes too, for planning.
Okay.
And also just to point out with preoperative planning, it's important to go into the OR having a plan, but sometimes that plan is a little bit different from what you see intraoperatively. So you always need option number 2, option number 3. So just because you have a plan going in doesn't mean you need to stick with it. So. All righty. So
let's see what they did. Ooh.
So they put on a laterally based fibula plate. As you can see here, there's no lag screw. So it leads me to more as it was a transverse or a comminuted fibula fracture in this location where they didn't put any screws here and span that area to act as a bridge plate. And then for the medial mal, they got a nice reduction here. We look at this shoulder and follow the medial mal in here to assess for a reduction there. And you can see that it's a nice straight line, or singular line. It's curved, but nice and nice reduction there. And they put one screw in the anterior colliculus, and then they put a pin in the posterior colliculus. Again, that's for rotational stability. And then they didn't address the posterior mal.
Once they got the fibula, I don't know. It's not like you got much out to length, but looks a little bit better reduced.
Yeah.
Let's see the next one. What's the next case?
All right. Anybody want to
boy.
shot?
This patient's having a rough day.
So Lisa just asked, what's the thought on leaving the posterior malleolus alone? Is it because the syndesmosis is not involved? It's a good question. So the posterior malleolus is attached to the fibula by the posterior inferior tibiofibular ligament, and that's one of the ligaments that's part of the syndesmosis. So an injury to the posterior mal, you know that the syndesmosis is injured as well. There was a study done looking at if you fix the posterior mal, you impart more stability to the syndesmosis than you would if you didn't fix the posterior mal and put a syndesmotic screw in. So a lot of the times at our institution, we'll go after even smaller posterior mals than what Joe touched on, just for that fact that if we can fix the posterior mal, that will give us more syndesmosis stability. So I think these slides and x-rays are from a couple of years ago. So that might have been before that study came out. I would have definitely fixed that posterior mal fragment.
Trauma nerd.
That's right.
Anybody want to take a shot at this one?
I mean, I could try.
Do it.
Okay, so this looks like mortise because it looks like there's some inversion.
Sure.
Or is it an AP?
Mortise, I mean, it's reasonable.
Okay, so it looks like a mortise in a lateral view of a skeletally mature individual's ankle. There's a transverse fracture of the medial malleolus that looks displaced.
Nice.
There's also what looks like a spiral fracture of the lateral malleolus, and it kind of travels up into the fibula. And like the distal portion looks a little displaced to me.
Now, Mina, when you look at this, do you see one clear spiral fracture line, or do you see maybe a couple of lines there?
I see a couple of lines.
So I think the spiral nature of this fracture pattern or this oblique orientation shows to you that it's a rotational type of injury. But I think that there's some other things going on there in the bone that we might describe with maybe some degree of comminution there. It's a little bit of a higher energy injury than maybe the other one. And then, so I think you did a great job describing it. How do you feel about this? Let's say you see this x-ray after you put a splint on. How do you feel about it?
So just putting a splint on, like after you reduced it and put a splint on it?
Do you think this, so the patient comes and they're already in a splint from super duper outside hospital clinic that sent you this patient. What do you want to do? You think this is good enough, or you want to leave it, or you want to try to make it a little better?
I want to try to make it a little better just because it looks like it's displaced and you don't want
Jeremy's
arthritis.
Yeah, exactly. Jeremy's going to point it out, but you can see kind of the tibia-talar joint here is not super well reduced. The tibia is medially translated in relationship to the talus. That gap there kind of tells you you're not where you need to be. So without even looking at the fibula, which you know is short and you know is deformed here, you can see that these spaces are not symmetric, and this is really not somebody who you want to just leave like this.
On the topic of like the surgeries for post-op for like ankle fractures, is there like a type of range of motion that you guys emphasize the patient gets first? Like in knee surgeries, it's like extension then flexion. Like do you do dorsiflexion versus like plantar or inversion? You know what I mean?
I think it's surgeon dependent. Certainly, it's fracture dependent in terms of how early you want to move the patient. I don't think necessarily there's any issues related to dorsi or plantar flexion first in order, but I think different surgeons have different weight bearing protocols. You know, the old dogma is 6 weeks of non-weight bearing with initiation of range of motion at some point, 3 to 6 weeks post-operatively. And then, you know, some of that depends on how your soft tissues look, how well the skin is healing, and how much work you had to do in surgery. And then usually the dogma is whatever you're doing, you kind of double that for diabetics in terms of weight bearing at least. And so there are some emerging schools of thought that I'm sure Jeremy could tell you more about, but that are, you know, advocating for earlier weight bearing in these patients because of ankle stiffness that develops kind of in a more aggressive PT protocol. But in short, no, there's not a big difference between dorsi or plantar or directional movement. It's more of just when.
Is this a supination external rotation injury then?
What do you think?
That's what I think.
Yeah, I think so. Jeremy?
Sorry, what?
What kind of a pattern you think this is?
So either,
The fibula's a little high. That's the only thing that would make
Yeah.
me pause on SCR. See what Jeremy thinks. Then I'll
Because
just
there's
yes,
two-
whatever he said sounds smart.
yeah. I think these are all cop-outs because these, I want better x-rays. But I think given the comminution and the location of the fibula fracture, that it's a little bit higher. So it's a B or a C in the Danny Weber classification, that I'm leaning more towards a pronation abduction.
PER,
No, AB.
PAB.
So the pronation external rotation, if I got rid of this portion here, this comminuted portion, I would say, and it's also the wrong orientation of right? So the PER would be the opposite obliquity of this fracture. So I'm throwing that out because of that. And also I'm throwing out the SER because the majority of the time they start, oh crap. Sorry. They start down here at the joint and they spiral up like this. So that's what you're going to get for your SERs. And then your PERs are going to be up high here, and they're going to be this orientation. So I'm throwing both of those out because of those differing, they don't have those obliquity of the fracture, and because it's comminuted and it's above or infrasyndesmotic, I'm going to call it a pronation abduction injury.
Well, they do.
You agree, disagree?
Yeah, that's a good explanation.
Yeah. So again, they bridge this area of comminution and put up 2 screws in the medial mal. Given the time, we'll just go on. So this one, again, transverse medial mal, a Danny's Weber C fracture that it's high. Here you can see that there's much more dislocation on the lateral, that it's posterior dislocated. So for this, again, a similar thing, they ended up putting 2 lag screws in. So here's a lag screw, here's a lag screw, and they expand the entire fracture. And again, a common recurring theme for your transverse medial mals, they're going to get some screws. So this is what we were talking about earlier with their SADs, our supination abduction. So they can get impaction on this area. And the reason why they always get impaction to the stable portion, so the distal tibia, right, continues up proximally. So this whole portion of the bone is stable. So when the talus hits into it, that portion's stable, it's not going to go anywhere. So if it gets hit into it, it's just going to deform and get some impaction injury. This portion, the medial malleolus fracture, that's not stable. So as that gets hit, it's going to shear that portion off. And so that causes the fracture, but the medial mal portion never gets any impaction to it. It's just this intact distal tibia portion. That's the area that has the impaction. And as you can see here, like we described, you either put a freer or some type of osteotome in this area and then lever it down so you can restore your articular surface. And then as we mentioned before, the majority of the time you're going to put a buttress plate on. This just shows some screws. screws are adequate, but this portion, that medial mal wants to go in this direction. So it's much more mechanically stable if you put a plate on, acting as an anti-glide buttress plate to prevent that vertically displacement. These screws are going to do it, but they're not as strong as this plate would be. So this is an example of this. So as you can see, these aren't great x-rays, and the fact that they're not a perfect AP, mortise, or lateral. And this is often what you're going to get in the trauma bay as these patients come in with a gross deformity. But what you can see here is this is our medial mal, and that's a nice vertically oriented fragment. Here on the fibula, we have a transverse fibula fracture. And then again, here we're looking at this portion, we're looking for impaction. And these, after we reduce them, you should always get a CAT scan, and that's going to further assess for your impaction. So here now, once we reduce it, you again can see that there's this vertically oriented medial mal fracture. There's this transverse fibula fracture. And if you follow the joint, you can see that it starts going up like this. So there is some impaction at this portion. So as we discussed, for the fibula, you're going to want to put a plate on because this is going to be better for rotational control. And then for the medial side, they pretty much did a kind of like a buttress plate. So what you can see here is you can take a plate and cut it down, so it acts as kind of like a big washer. And so they put this screw right above the apex of the fracture. So with this washer here, you're still creating a small axilla, similar to acting like an anti-glide plate. So there's this axilla here that they created from this washer. So kind of the same idea, just an interesting construct. And again, this x-ray is probably from like 15 years ago. So as we touched on, the posterior mal, more than 25%, you're going to always operate on it, but it's going to give you some more stability to your syndesmosis if you fix it. And there's a bunch of different ways to fix it. The most ideal way is to go from a posterior approach, either a posterior medial or posterior lateral approach to the ankle. And you want to reduce it and then put lag screws. The ideal would be from the posterior to anterior directed. This way you can get more screw purchase anteriorly. As you can see here, there's much more area to work with. We always talk about pinning a pitcher to the wall as opposed to the wall to the pitcher. So the pitcher is this small posterior malleolus fragment. The wall is this much bigger remaining tibia. And so we want to pin the pitcher to the wall. And so take the small portion and put it to the bigger portion. That's going to allow us for much more screw threads in this area as opposed to this area if we just had screw threads here. And then similar to your medial mal that are vertically oriented, another great construct would be to put another anti-glide plate on here. So you put a plate here, a screw right at the apex. That's going to cause you to form an axilla here and prevent vertically displacement of your posterior mal. Put another screw here, and then you can put some lag screws. Sorry, that's a bad screw, but you guys get the idea. Again, you can put these lag screws from posterior to anterior so you get more thread purchase. So once you fix the fibula and the medial mal, are you done? And the answer is no. You want to check to see if you need any further fixation of your syndesmosis. And a way to do this is you can do a cotton test, which is just, depicted here, where you put a bone hook on the fibula and you pull out laterally, and you check to see if there's an increase in the the lateral and medial clear space. Or you can do an external rotation stress test where you get your mortise and then you externally rotate the foot. And again, you're going to look at your medial clear space compared to your superior clear space and see if there's a increase in that. If there is, then you want to put a syndesmotic screw in. And you can see in this depiction here that the fibula is a posterior lateral structure. So it's a little bit more posterior to the tibia, about 10, 15, 20 degrees in patients. And so you have to account for that when you put a syndesmotic screw in, which is going to be a screw from your fibula across to the other side of the tibia. So you need to drop your hand by about 15 degrees so that it comes in this orientation. If you don't do that orientation, then you can theoretically mal-reduce your syndesmosis. So this is just showing that there's a lag screw, neutralization plate, and you can see here that they probably didn't do a stress test or a con test, because now here in their splint postoperatively, you can see that this medial clear space is much greater than our superior clear space. So there's an injury to the syndesmosis that they didn't pick up after they fixed the fibula. So when do we fix these? They can be either immediate or delayed. Immediate are going to be anytime you have an open fracture, or sometimes you have irreducible ankle fractures, or you can reduce it, but you can't hold it. A lot of times they'll just, even in the splint, they'll fall out the back. So those you have to fix rather quickly. And this is a picture of a open ankle fracture. But a lot of the times we're going to delay, and a lot of times we're delaying this because of swelling, especially if you have any ankle fracture dislocation. Those are going to swell up, and they might not be swollen initially when you reduce it, but over the next couple hours, they're going to swell. So if you see one at 3 p.m., you mid it to try to do it the next day at 7:30, you're going to be in big surprise that it's going to be too swollen for surgery at that point. Often we see patients that come in delayed presentation, or they're walking on it. If a patient has diabetes and are insensate, they may not notice they have a fracture right away and walk on it. All that stuff is going to cause additional swelling and may need to delay the surgery further. So we'll just skip this given time. A way to determine if it's ready for surgery is this wrinkle test, where you check the skin, and if it wrinkles, then it's not swollen enough for surgery. Postoperatively, we put them into a well-padded splint, and we'll keep them in that splint until the sutures come out in 2 to 3 weeks. A lot of new literature is coming out about when do you allow patients to weight bear. It's still thought to be 6 weeks, but now people are trying to start weight bearing sooner, and there's a study in the metric people are doing that are looking at earlier weight bearing. So that should be coming out shortly. That may change this whole weight bearing post-operatively. But if you do a syndesmotic fixation, you need to increase your non-weight bearing longer, and the same for diabetics. You want to increase their non-weight bearing for additional weeks. So again, we can, I guess just given time, I'll just run through these quickly. So ankle fracture dislocation, they put a lag screw on and a neutralization plate and then medial mal screws. However, if you guys look here, the level of the distal fibula is pretty much equal. That was a crappy line, but it's pretty much equal to your medial mal. Your distal fibula should be more so in this position. So that's that teral crural angle that I touched on before. It should be about 83 degrees. And so this is how it normally should look, with this distal fibula being more inferior than your medial mal. So you have to pay attention to that. And so as you can see here, we didn't get enough length. So they revised it, and now you can see that it's much more distal. And so the length was adequate now. And then the last case here, I think this is the last case. This was what we posted on the Instagram as a question. As you guys can see here, there's no fractures that you can notice here. The medial mal is intact. The distal fibula is intact. However, there's this increase in the medial clear space compared to the superior clear space. And you can see an increase in the distance between the fibula and the tibia on the lateral aspect. So there is some type of syndesmotic injury here. And the question I posted on Instagram was, what should you guys do next? When you see this in the ED, what should your next step be? And that would be to get a tibia fibula x-ray. So you want to assess for the whole bone, because there's likely going to be a fracture superiorly. This is called a Mason-Neuve injury, where you get a rotational injury and the force comes up through the medial mal, through the syndesmosis, and then it exits up high superiorly, and then you often will have a fracture up there that you're not seeing if you just get ankle x-rays. You do not need to stress these because it's already wide. So your stress test isn't going to give you any additional information. You're just going to give the patient more pain from twisting their ankle. A CAT scan isn't really needed. There's no fractures here that you're going to assess better with your CAT scan. And then the contralateral or comparison x-rays are good, but it wouldn't be the first thing that you do. That's going to be more so when you're planning for operative fixation, because that's going to allow you to reduce this injured ankle and to the proper position compared to the normal contralateral ankle. So again, here they did a bad job here where they put screws in for the syndesmotic injury, but they didn't reduce it. You can see that it's still wide here on the medial side, and then there's still a large distance between the tibia and the fibula there. So this is much better, where the space in the medial clear space to the superior clear space is about the same. And then if there is a fracture superiorly, you don't have to fix that. This construct will give your ankle enough stability, and you don't need to chase after the fibula fracture. So I think that's all we got. Anybody have additional questions? Joe, do you have anything to comment?
No, I think there's some kind of marathon award there should be for making it through a Galloway lecture.
Yeah,
That was a long one.
that was like 100 slides.
Yeah, nice job. Nice job, Jeremy. Nice job, Joe. Even though you're not here, buddy. We miss you. That's all I have to say. You guys have any questions?
Oh, I'm just looking. There's a question here. Do you put them in an X-fix if you delay, or do you just keep them in their splint? So if you have X-rays that show an adequate reduction and you're just delaying because their skin is too swollen, you just keep them in the splint. You'll only put something in an X-fix if it's unstable. So say you get it reduced, but it keeps on losing that reduction. You have two options. One, you can just fix it right away. Or two, if it's too swollen, then you'll put it in an X-fix just to hold that reduction. Because any millimeter of translation or joint incongruity causes, I think it's like 43% increased contact forces to the joint.
42. 42.
Damn it.
Mm.
I'm going to fail my OIT. So
Remember
you're
when residents used to scream out the author name in morning report? Just scream it out.
well, that increased contact forces is going to cause a higher rate of post-traumatic arthritis. So. And the same thing is not we didn't mention, but for open ankle fractures, you're going to still just wash out that open injury and then just treat it like a normal ankle fracture. You don't have to delay it. You don't have to put in an X-fix. You only would do that if it's too swollen to treat initially.
Cool. All right, guys. Thanks for coming out. Hope this was helpful. We'll see you in 2 weeks.
Yep, thanks, guys.
If you guys like the cases, we can maybe start doing some more cases if you guys like that.
Yeah.
Yeah, I like the cases.
Yeah, same.
But like maybe like make it more like interactive, like be like, oh, this is an open fracture. What would you do first? XYZ. I don't know.
Got it. Well,